been given. So I would like to invite Dr. Ani Sreedhar for the first talk. She's a senior consultant, Little Flower Hospital, Angamali. Madam will be talking about certain orbital surprises.
So, Indu asked me to talk on orbital surprises. So, it's orbit, in every case, it's a surprise actually, because it's compared to the Pandora's box where you can you get all sorts of things like, coming out of the orbit. So, your life is always interesting if you are an orbital surgeon. Let's come. Okay. So this was a man who came with a middle-aged man who came with a soft boggy mass in the medial part of the orbit. The swelling was in the lacrimal sac area mainly, extending above the medial papillary ligament. And the thing was, there were engorged vessels over it when he was doing a Valsalva maneuver, but there were no visible or palpable pulsations. So CT scan showed that it was extending into the nasolacrimal duct, and there were no feeder vessels seen. So when we went in through a theatre of incision, so I thought that it is somehow connected to the sac. So we went into a theatre of incision, and we found that the pathologist came up, and on table itself we realized that it was a lacrimal sac rhinosporidiosis. So it was confirmed by the pathologist. So lacrimal ocular rhinosporidiosis is called oculosporidiosis, and it's seen first in the inferior turbinate area when the patient takes bath in unhygienic in ponds which are becoming rarer in Kerala now. So and then it spreads to the canal through the NLD into the lacrimal sac. So the ENT surgeon, do not give this case to the ENT surgeon first, because ENT surgeons cannot deal with the sac rhinosporidiosis. You do an external DCR or a DCT or fulgurize the sac. It's a case of lacrimal sac. You would have seen it, no? So then you give the case to the ENT surgeon. Do the sac surgery first, and intubate if you want, and then give the patient to the ENT surgeon. Do not do a DCT and finish it off and then give. The ENT surgeons themselves told me, you do a DCR, intubate, and then give them to me, so that then they can tackle the lower part of the sac, the nasal part. So this was a man who came with a protrusion of the left eye for 1 year, and there was recurrent attacks of pain, redness, and he gave a history of carcinoma of the vocal cords, which was treated. It was a squamous cell carcinoma treated with radiotherapy, and he had all sorts of comorbidities, and the extraocular movements were all restricted, and there was lag of thalamus. There was a ill-defined mass in the inferior orbit which was extending into the orbit. Posterior margin could not be felt. CT scan showed non-homogeneous mass, and the maxillary sinuses were also, there was a chronic sinusitis. So our first diagnosis was maybe it was an orbital abscess due to maxillary sinusitis. It could be fungal. Metastasis was less likely, but was a diagnosis. So, but histopathology came as adenoid cystic carcinoma of the left orbit. We double checked with two pathologists. It was an adenoid cystic carcinoma of the left orbit. So, the primary site of adenoid cystic carcinoma is in the lacrimal gland, and the lacrimal sac region is quite rare. Only 3 cases have been reported. I don't know if Fairuz knows about some more. So another case with watering of the right eye, and always when the patient comes to you with proptosis or a mass, you have to look at take note of the temporal region and also the cheek. There may be a fullness there. So this was a cheek fullness. The patient was diabetic, and there was again an ill-defined mass there extending into inside the posterior margin, could not be felt. The CT scan showed a mass filling the maxillary sinus and extending to the orbit with extensive bone erosion. So it was diagnosed as a sinonasal malignancy, and the mass was also pressing on the Hasner's valve by the endoscopy. So histopathology came as plasmacytoma of the sinonasal cavity, which is a localized form of multiple myeloma. So when there is extensive bone destruction, punched out lesions in the bone, think of plasmacytoma or multiple myeloma. This was a man who came with a superior orbital mass, and there was a bone excavation. It was nearly intended up to the dura. So I suspected the worst, but through, I don't know where. It's nothing. It's through the lid crease. Play Jeda. I can't do it from here. Not playing. Okay, it played. I think I can't click there. Through the upper lid crease incision, we could see after entering below the lid margin, it was a hematoma. So this is like a child with a history of fall and a skin abrasion, but it was a mass. There was a mass palpable, and it was a primary neuroectodermal tumor, which is very malignant. Again, a protrusion which lasted for 2 years. The patient came to us with hypotropia, defective vision, diplopia. In such cases where the eye is pushed very much to one side, there may not be diplopia because the image is forming at the very periphery of the retina. And all movements were restricted, and CT scan showed lacrimal gland mass with calcification, and there was RAPD, disc edema, choroidal folds. So we thought it would be a adenoid cystic carcinoma of the lacrimal gland, but it was an adenoma of the lacrimal gland, and we double checked with two pathologists again, and the patient, the post-operative appearance, was asked to come very frequently, but still he is not followed up. This was a bilateral lacrimal gland mass, which on table was, the appearance was like this, follicular reddish, slightly yellowish, and there was congruent positive staining diagnosed as amyloidosis. This is my favorite slide. Actually, Indu had worked up this patient, green apple briar frangulence. So that was the diagnosis of amyloidosis. But there were lots of lymphocytes, so it was positive for CD20 and 138. So it was again re-diagnosed as a lacrimal gland lymphoma. And bone marrow was also positive, as also the peripheral smear. So it was an extranodal marginal zone lymphoma of stage 4. And only 18 cases had been reported till 2014, and only one case with lacrimal gland amyloidosis and lymphoma, so in 2016. So they say that pathologists should be aware of the lacrimal lymphoma part when they are diagnosing an amyloid of the lacrimal gland. This was again a lacrimal fossa mass with pain redness, which was cystic in nature, and there were sheets of abundant eosinophilic cytoplasm, microcysts with eosinophilic secretion. It was an oncocytoma. All these are quite rare, but we have not reported them. That's the problem. So parathyroid, so PET scan was done. There was a parathyroid swelling, and it was FNA seed, and it was a parathyroid oncocytoma, and there was a huge kidney swelling. Nephrectomy was done, and we thought, oh, it's a renal oncocytoma, but it was a renal cell carcinoma, clear cell carcinoma. So that is why I said that all these orbit cases throw up surprises, and your life can never be boring. So uncommon things can occur uncommonly, but think of common things first. But without all these pathologists and all these people, we could never have diagnosed all these cases. So thank you.
Thank you, Annie ma'am, for that wonderful collection of cases. Orbit is indeed a